Today we're going to be talking about examining the pharmacologic profiles and appropriate integration of treatment advances in AML. And it's such an honor today to bring up here Dr. Fausel. Dr. Fausel is at the Indiana University of Health. He is chair of the Hoosier Cancer Research Network in Indianapolis, Indiana. Dr. Fausel received his Bachelor of Science in Pharmacy as well as his doctorate in Pharmacy from the Albany College of Pharmacy before completing an ASHP residency at the Samuel Stratton VA Medical Center. Most of you are well aware of Dr. Fausel's accomplishments, highly published in the oncology literature, especially with salvage chemotherapy, germ cell cancers, and so forth. So, without further ado, Dr. Fausel.
Thank you, Randy. Thanks for inviting me. It's great to be here. I don't have any disclosures. Learning objectives. So I imagine not everybody in this room takes care of AML patients every day. So I'm going to give you a little bit of background on the disease and the historical treatment. And then I'm going to launch into some of the newer agents that have been approved just within the last year and a half. And it's been really quite a remarkable turnabout from a disease that had almost no demonstrable progress for 4 decades to the point where we have several new agents that have been approved in the last 18 months. So this disease is a terrible disease. There's no two ways about it. Acute myeloid leukemia, it impacts approximately 20,000 patients in the United States each year. Unlike the other famous acute leukemia, acute lymphoblastic leukemia, that disease primarily affects kids, and we do quite well with curing kids with ALL. AML primarily affects older adults. Median age is in the late 60s. Now, that's not to say you can still have, actually there are some cases of pediatric AML, there are some cases of younger adult AML, but most patients are going to be in their 60s and 70s when they're diagnosed with this disease. The 5-year survival for this disease is miserable. It's less than 1 in 3 patients. So we have not really moved the needle in terms of being able to improve cure rates for this patient group. Now, how does a patient get diagnosed with this disease? You have to have greater than 20% of the cells in your bone marrow be classified as leukemia cells. So we colloquially refer to leukemia cells as blast cells because blast cells are undifferentiated cells. They haven't kind of figured out what they want to do yet and what sort of mature form they want to take. In a normal healthy bone marrow, like hopefully all of us have, we have some healthy normal blast cells because they just haven't committed to a more mature progenitor yet. But it's only less than 5% of all the cells in our bone marrow. Okay? In a leukemic state, once you get above 20% of all the cells in your bone marrow as blast cells, then you can be classified as acute leukemia, either acute myeloid or acute lymphoid, depending on the cell lineage. Now, this is a diagram that actually shows you the offending cells that I'm talking about. See that big, ugly purple cell there with the huge nucleus on both sides there? That is a blast cell. They should not be in your peripheral blood. Okay? Blast cells should only be in the marrow. When someone has blast cells in the peripheral blood, you're in big trouble. It means you have acute leukemia. Now, is that always the case? Okay, and in all the years that I was taking care of acute leukemia patients in the inpatient side, I had one instance where a patient had peripheral blast, then they ended up not having leukemia. And it was, oddly enough, it was an aunt of a pharmacist that I worked with. So I got a call on a Friday afternoon from this pharmacist, and she's like, hey, my aunt in southern Indiana was just told she has acute leukemia and that she needs a transplant or she's going to die. And they were going to send her to some small community hospital. I said, well, get her transferred up to IU and we'll take a look at her. And fortunately, the attending really was great and was able to get her in on a Friday afternoon. I think it was like a holiday weekend. So it turns out this woman had some sort of really weird viral infection, and all of her counts were suppressed. And when they did a bone marrow biopsy, there was no malignant cells. So she had some very strange, and we could never isolate what it was, but some sort of viral exposure. And she just had an extreme left shift and had some of those immature blast cells make it out into the peripheral blood. But they went away within a couple of days. So That's the one time that I saw someone not have blast cells in the peripheral blood and not be acute leukemia. So if you have blast cells in the peripheral blood, you have acute leukemia. Now, classically, acute myeloid leukemia was categorized into different groups. This is the French-American-British criteria, which is kind of fallen out of favor now. Now people are starting to take a look at more genomic-based characterizations of acute leukemia to put them into different treatment groups. Signs and symptoms. Well, what happens in acute leukemia is that population of leukemic cells starts to take over and dominate the bone marrow at the expense of the normal bone marrow cells. So you don't make adequate amounts of neutrophils, of red blood cells, of platelets, of lymphocytes, because the leukemia cell is dominating and it's producing leukemia cells that they don't work. They don't fight infection. They just take up space. So what you're going to see clinically in a patient is the sequelae of a bone marrow failure state. You're going to see patients with anemic complications because the red blood cell count is low. You're going to see perhaps hemorrhage, frank hemorrhage, or subtle bleeding events because the patient's platelet counts are going to be low. And you're going to see infectious complications because the patient doesn't have adequate amount of neutrophils to fight off infection. Now, once you figure out what a patient actually has, whether they have acute myeloid leukemia versus acute lymphoid leukemia, the next question from a patient standpoint is like, okay, I know what I have. How am I going to get treated, and what are my chances? And this slide actually gives some information that helps physicians educate patients and family members about what their chances are with responding to therapy. So for about 30 to 40 years, we've been able to go and actually examine the mutations of interest in leukemia cells. They're often referred to as cytogenetic abnormalities, but that's just a fancy term for a mutation. So you can examine the mutations in leukemia cells in the laboratory. Not every patient is going to have a very obvious mutation that's able to be picked up in the lab, but most of them do. And there's enough experience now with following patients in large groups with acute myeloid leukemia where we can actually categorize patients into 3 general groups based on the mutations that are present. So we have a favorable group, which means, hey, if you're in this favorable group, you have a better chance of achieving remission with chemotherapy, and you have a better chance of staying in remission with chemotherapy. If you're in the intermediate group, it's basically average. You have an average remission rate, you have an average life expectancy, an average remission duration. And if you're in the adverse or poor risk group, you have a very high chance of, number one, not even really responding to your chemotherapy and not achieving remission. And if you do achieve remission, your remission is likely to be short-lived. So what are our treatment goals with acute myeloid leukemia? Obviously, we would like to be able to cure the patient. That's not always going to be possible. Again, when you think about the age group of the patients that are going through intensive chemotherapy, this is tough chemotherapy to get through. And I'll get into the more specifics about that. But it's tough chemotherapy to get through. And if many of your patients are older and they have a number of medical comorbidities and they're getting intensive chemotherapy that's going to completely wipe out their bone marrow and keep them in the hospital for a month, neutropenic and thrombocytopenic, that's a tough thing for patients to have to endure, especially if they have compromised hepatic or renal function or other comorbidities, cardiac compromise. So our goal is cure, but it may not always be realistic. So what are our short-term goals? Well, first off, you have to get your patient into a remission with your initial chemotherapy, okay? And to do that, the way that you go about it is you give combination chemotherapy, usually with Cytarabine and Daunorubicin. You let the patient's counts go down to 0, and then after a period of time, those counts are going to recover, hopefully with normal hematopoietic cells and not leukemia cells. After they recover their counts, you do a bone marrow biopsy. And once you do the bone marrow biopsy, you're looking for 2 critical pieces of information. One, are all the leukemia cells eradicated? Okay, so there should be no evidence of leukemia cells in that bone marrow if the patient has achieved remission. And 2, does the patient have normal hematopoiesis restored, or did their blood counts come back to normal? Okay, so if you get that post-remission or post-induction therapy bone marrow biopsy, no leukemia cells in there, meaning there's less than 5% blasts, and their blood counts come back to normal, they have achieved remission. Now, remission does not translate to cure. Remission is just the first step on the road. Okay? So if you were just to treat your patients with one cycle of induction chemotherapy and they achieve remission, 100% of those patients will relapse with leukemia. Now, the question is, well, why? Am I lying to you? I just told you that there's no more leukemia cells in the bone marrow and all the blood counts have come back to normal. And yes, that's true. But the thing is, there's something in acute leukemia called minimal residual disease, which means there are still leukemia cells there, but we're just not smart enough to find them. They're there. They're hidden in the bone marrow. They may be in other tissue in the body, but they are there, and they make themselves known after a period of time if you stop treating the patient. And all those patients will relapse if you only give one cycle of induction chemotherapy. Okay? So remission is just the first step on the road to getting people through this disease. Then you have to give further cycles of chemotherapy to try and achieve cure. Or you could offer a patient a bone marrow transplant from a donor, which we refer to as allogeneic from a donor. Allogeneic, you'll hear hematopoietic stem cell transplant or bone marrow transplant. Those terms are used somewhat interchangeably. So I had alluded to the drugs that had been used historically for the treatment of acute myeloid leukemia. So I don't know, maybe we're just not that smart as cancer caregivers, and so we have to come up with really simplistic names to name our chemotherapy regimens, like CHOP for lymphoma. We're even simpler in acute leukemia. We just have to use numbers. So we use 7+3 to describe the induction therapy of Cytarabine, an old anti-metabolite drug, and Daunorubicin, an old anthracycline. You know, the 7+3 has been the mainstay of therapy for the treatment of acute myeloid leukemia since the 70s. And you know what you're going to get. You give these folks 7 days of continuous infusion Cytarabine, 3 days of IV push Daunorubicin. Approximately 70% of patients are going to achieve remission. Okay, that's been the standard approach for many, many years. Now, what happens after the patient finishes induction therapy and they hopefully achieve remission? What's the next step? The next step is either, you can call it two things, post-remission therapy or consolidation therapy. Basically, they mean the same thing. And there are three options for post-remission therapy in patients with acute myeloid leukemia. One, you can give them more chemotherapy, and that's typically with a higher dose of Cytarabine, where you give either 3 or 4 more cycles about a month apart. Or you can offer them a bone marrow transplant from their own cells, an autologous bone marrow transplant, or you can give them a bone marrow transplant from a donor, an allogeneic bone marrow transplant. There have been many randomized trials to try and ascertain whether more chemotherapy with high-dose Cytarabine, an autologous stem cell transplant, or an allogeneic stem cell transplant is the best thing to do. And all of those therapies are basically tied for first and tied for last. They're exactly the same in terms of their overall survival. Why is that? Well, because with high-dose Cytarabine and with autologous stem cell transplant, those patients have a higher risk of relapse. And the folks that get allogeneic stem cell transplant, they stay in remission for longer, but more of those people die because of complications of the allogeneic stem cell transplant from either infection or complications of graft versus host disease. So that's why the overall survival evens out. So that was it. That's all you needed to know about acute leukemia for many, many years until now. So what was the first step on the road for us getting better therapy? Well, the first step actually involved using older drugs, except reformulating them. And so packaging Cytarabine and Daunorubicin into the same drug, but encasing it into a liposome, was the first step of an FDA-approved agent to try and improve outcomes for patients with acute myeloid leukemia. The nice thing about it is you can give short infusions of this drug as opposed to having to have patients get continuous infusion cytarabine over 7 days. So what's the evidence to support the use of this new formulation of cytarabine and Daunorubicin? Well, there was a phase 3 trial that was conducted comparing the standard formulation for induction and post-remission therapy for acute myeloid leukemia versus induction and post-remission therapy with the liposomal formulation of cytarabine and Daunorubicin. Let's look and see what the efficacy results were. When you look at the median overall survival, which was the primary endpoint of the trial, it was approximately 10 months for the liposomal formulation of cytarabine and Daunorubicin. Okay? The standard formulation of cytarabine and Daunorubicin, the median survival was approximately 6 months. So an improvement in 4 months. Now, if you don't read a lot of oncology clinical trials, you may be asking yourself, okay, 4 months, what's the big deal about that? What I would say to that is a big deal in the oncology world because these are such tough diseases to treat that we're jumping up and down when we see an improvement of 1 month of therapy A versus therapy B. So to see an improvement of 4 months is significant. And the other thing I want to point out about this slide is look down at the bottom of the slide where you see all-cause 30-day mortality and 60-day mortality. That means how toxic was this therapy and were patients able to tolerate it? And when you look at the rates of the liposomal formulation compared to the standard cytarabine formulation, they're about half. Okay? So one thing I didn't point out in the last slide, which I should have, which I'll tell you now, is this was a very high-risk patient group. These are patients that they've either had a syndrome called myelodysplastic syndrome that transformed into acute myeloid leukemia, or they had some sort of poor risk features which made it very unlikely that they were going to respond well to their treatment. So this is a very high-risk group of patients, and so for them to respond as well as they did in this clinical trial is pretty striking. These are the Kaplan-Meier survival curves. So on the top, the blue is the liposomal formulation of cytarabine and Daunorubicin. The orangish color is the conventional form of cytarabine and Daunorubicin. So clear difference between the treatment arms. When you look at the toxicity is pretty much what you would expect from this patient group. So you're going to see certainly profound myelosuppression. So you're going to see neutropenia, you're going to see thrombocytopenia, you're going to see anemia, and you're going to see complications thereof. You're going to see infectious complications. You're going to see febrile neutropenia. You're going to see pneumonia and hypoxia as a result of that. You're going to see fungal infections. You're going to see GI toxicities because guess what? Daunorubicin causes mucositis. And cytarabine causes lower GI mucositis and colitis. So all of these are pretty standard toxicities that are reported for patients that undergo this treatment. The one thing I would point out is they're about the same in each treatment arm, and based on what I showed you in the efficacy slide, the overall toxicity that led to deaths in the liposomal arm were less. So we have a new therapy that you can use right from the get-go in patients that are newly diagnosed with high-risk AML. So these patients are at high risk for either not responding well to their therapy or relapsing quickly. And this therapy was reasonably well tolerated with less patients that had early deaths because of toxicity. So the next drug I want to talk to you about is a drug called Midostaurin. And so this is a FLT3 inhibitor. So what is a FLT3 inhibitor? It turns out there's a specific mutation in some patients with acute myeloid leukemia, which involves the FLT3 gene. And there are a couple different types of FLT3 mutations, but Midostaurin appears to inhibit the tyrosine kinases that are associated with both of those mutations. These patients tend to do less well compared to an average patient with acute myeloid leukemia. So it's an aggressive leukemia. So it's an oral formulation that can be given twice a day, and it's typically given in combination with standard chemotherapy with cytarabine and Daunorubicin. So how well did it work? So this trial actually took younger patients. So this is a patient group that actually does reasonably well with chemotherapy compared to our older patients that get chemotherapy. And they were randomized to get either standard Cytarabine and Daunorubicin versus Cytarabine and Daunorubicin plus Midostaurin. Now, the Midostaurin did not overlap the chemotherapy. You'll notice they didn't start the Midostaurin until the chemotherapy was finished on day 8. And then they would get Midostaurin from day 8 to day 21 with each cycle of chemotherapy. And then when they were done with chemotherapy, then they would go on oral maintenance therapy with Midostaurin. So how did patients do? The median overall survival was markedly improved in the Midostaurin-containing arm, basically 75 months versus 25 months. When you look at the 4-year overall survival, it was improved, not to the same degree as the median overall survival, because again, as you get farther out, you're going to see a little bit of those survival curves coming together, but still a significant increase compared to the chemotherapy alone. And when you look at some of the other indicators of efficacy, how long did patients stay in remission, which is reported out as disease-free survival, improved in the Midostaurin-containing arm compared to those that got placebo. What percentage of patients actually achieved remission? Better in the Midostaurin arm compared to those in placebo. Well, how was the toxicity profile? Was Midostaurin a really toxic compound to add on top of chemotherapy, which we already know is toxic? And really, you have to look pretty hard on this slide to find a difference between the toxicity between the standard of care therapy arm and the Midostaurin-containing arm. One area which I would point out is there is more rash in the patients that did receive Midostaurin. So yes, there is a risk of increased cutaneous toxicity with this compound. So the next drug, Gemtuzumab Ozogamicin. The names get better as we go along. So this is a really cool drug. It was initially approved for AML back in the year 2000 and was taken off the market because of severe hepatic toxicity, particularly in patients that went on to get transplant. There's a form of hepatic toxicity called hepatic veno-occlusive disease that transplant patients get. The rates were really unacceptable in the patients that had received Gemtuzumab Ozogamicin, so it was removed from the market. Well, the folks that developed the drug were like, hey, you know what? We still think this drug has potential. We just have to use it better so patients don't get so much toxicity. So what they did is they changed the dosing, and they broke up the dosing, and they made the dosing less to hopefully still gain anti-leukemic benefit, but spare the patients the toxicity associated with the drug. So I'm going to talk to you about 2 clinical trials with Gemtuzumab Ozogamicin. The first is when you add it to regular chemotherapy with Cytarabine and Daunorubicin. So this is a newly diagnosed cohort of patients, a little bit older than the last trial. So these are patients older than age 50. So they're going to have a little bit tougher of a time with chemotherapy compared to what you saw in the last trial. And they got Gemtuzumab Ozogamicin not only added during the induction phase of treatment, but also in the post-remission phase of treatment. So how did patients do? The median event-free survival. Okay, well, what does event-free survival mean? Event-free survival means events are bad things. Okay, when you see event-free survival in a clinical trial, think bad. So what is a bad thing in a leukemia patient? Well, death, relapse, having to be taken off a study because of toxicity. So those are all bad things. So the event-free survival was almost double in the Gemtuzumab Ozogamicin containing arm compared to those that just got chemotherapy. So those patients that got Gemtuzumab Ozogamicin relapsed less, had less death associated with treatment compared to those that were treated with standard chemotherapy. When you look at the median overall survival, it was almost double in the patients that got the Gemtuzumab Ozogamicin treatment. And when you look at the risk of relapse, the folks that got the Gemtuzumab Ozogamicin, relapse was much farther out compared to those that just got standard chemotherapy. Okay, toxicity. One of the things that we learned in this trial is for some patients, it's going to take their blood counts longer to recover, particularly with platelets. Okay, so that has something to be said for it, and you're going to have to monitor those patients and possibly transfuse them with platelets a little bit more liberally than you would in a patient that didn't get gemtuzumab, ozogamicin. And just for the sake of curiosity, the way that we typically transfuse these patients that are going through treatment for AML is if their red cell count falls below 7 grams per deciliter for hemoglobin, they get a red blood cell transfusion. If their platelet count falls below 10,000, that's when they get a platelet transfusion. So one last point on this slide before I go on. Take a look at the last line, hepatic toxicity. Remember that was a bad deal with this gemtuzumab ozogamicin drug? It was elevated compared to those that just got standard chemotherapy. So the toxicity to the liver does not go away with this drug, even with the novel dosing and the fractionated and less total drug exposure. So that's still something that we have to keep our eyes on and stay in tune with. The next trial with gemtuzumab ozogamicin was in patients that are, again, older patients and generally would not be considered appropriate candidates for combination chemotherapy for the treatment of AML. These patients are too old and frail in most physicians' mind to be able to withstand going through 7+3 chemotherapy. So typically these folks may be offered some sort of palliative chemotherapy. Maybe they get smaller doses of sub-Q cytarabine. Maybe they just get hydroxyurea to control their counts and other supportive care measures. The question that's being asked in this particular trial is, okay, well, what if we give them a truncated dose of gemtuzumab ozogamicin just as a single agent compared to best supportive care? Is there value in treating this frail patient group with this active therapy compared to just giving them best supportive care? And the answer to that is probably. And when I say probably, the reason why I say that is you look at the median overall survival, it's 5 months versus 3.5. So not a huge improvement, but an improvement nonetheless. And I think if you have a patient that's staring across the room from you, just getting this news that they've been diagnosed with acute leukemia and they have diabetes and cardiac issues and have had a number of surgeries and you just don't think they're healthy enough to get treatment, you would think twice about perhaps offering them gemtuzumab ozogamicin. You can say, you know what, there is some benefit with this drug that perhaps may be a little bit more tolerable for you than just going through regular chemotherapy, and that may be a reasonable thing to do for some patients, particularly those that are insistent on wanting therapy. Toxicity. It was kind of striking to me looking at these numbers because the toxicity really wasn't all that different in the active treatment arm compared to those that just got best supportive care. So again, you know, you can try this with some patients that really are insistent on getting treatment and know that you're not going to be putting that them at undue risk for toxicity with a single agent gemtuzumab ozogamicin. Of course, you have to be very explicit about what your goals are as far as treatment. You can't mislead patients into say, oh, we're going to give you this new fancy drug and it's going to cure you and not have any side effects. And you just have to say, well, look, this may buy you a few extra months so you can go to your granddaughter's wedding or something along those lines. The next drug I want to talk about is first in class. Enasidenib is a drug that impacts IDH2 mutations. So what do IDH2 mutations, what's the deal with those mutations? Well, first off, it's not a common mutation at all. It's only in about 5 to 10% of all patients with acute myeloid leukemia. What appears to happen with this drug, or with this mutation, is once this mutation occurs, you get elevated levels of 6-HG. And 6-HG drives the leukemic phenotype. Okay? So the way that this drug works is it antagonizes 2-HG and lowers 2-HG levels so you can get normal, proper differentiation of hematopoietic cells. And it's an oral drug. So there's not a ton of data out on this yet. It got approved on the basis of phase 1, phase 2 data in a relapse treatment setting. So this is the group of patients that were studied. These are folks that had already gotten chemotherapy and they relapsed that did indeed have the IDH2 mutation. This is a relatively small trial. There was only about 100, 200 patients in it. And what they found is in this group that relapsed after standard chemotherapy, that you could treat them with a single oral drug, and approximately 40% of these patients would respond to a meaningful degree. And about half of those would actually achieve a complete remission. So if you were to give the same patient group salvage chemotherapy, the rates of remission, best case scenario, would be about 1 in 3. And the average time that these patients would be able to hang around would be about 4 to 6 months. Okay? So when you look at the median duration of response, that's just response. That's not overall survival. The median duration of response is 6 months. So you're already to the best possible case scenario end of just regular chemotherapy in terms of overall survival, but these patients are still in response, the ones that did achieve a response at 6 months as a median number. So this is intriguing. It's another treatment option. Granted, it's for a limited group of patients. Not too many patients have this IDH2 mutation, but it's still a step forward in my eyes. Toxicity. Well, there's some hepatic toxicity, there's some myelosuppression. The one thing that is interesting about this particular compound, and the next one that I'm going to talk to you about, is there's something called IDH differentiation syndrome. Well, what is that? So what happens is, if you think about the way the drug works, is you have something, 2-HG, which is suppressing normal differentiation. Okay? You remove or lower 2-HG levels, and then you get normal differentiation again. But what happens is you get an exaggerated response initially in terms of differentiation. So you get a lot of these cells which are being suppressed from differentiating, all differentiating at once. And some of those cells, because there's so many of them that differentiate at the same time, they make their way into the lung field. And when they make their way into the lung field, there's a lot of inflammation associated with that, and it brings some fluid in the lungs, and patients can have significant pulmonary compromise to the point where they could end up in the ICU on a ventilator. So what do you do about that? There actually is a very simple intervention that can spare patients the sequelae of the differentiation syndrome. You give them corticosteroids. If you give them 10 milligrams of dexamethasone twice a day, you can cut this reaction off in its tracks. So just having a little bit of knowledge of the supportive care, you can save your patient a lot of risk. Now, just a few months ago, there was a second drug. I don't want to necessarily say this is in the same class. It's kind of like cousins of the first drug. So there's an IDH2 mutation and there's an IDH1 mutation. Okay? And it's same deal with IDH1 as it is for IDH2. Relatively rare mutation in acute myeloid leukemia patients associated with elevated 2-HG levels. You give Ivosidenib, lowers the 2-HG levels, and patients start differentiating cells in a normal degree. Another oral drug. So this is the clinical trial data. Again, a smaller subset of patients, a phase 1 trial with a dose expansion. They settled on the 500 milligrams as the maximum tolerated dose to be carried forward in subsequent clinical trials. In terms of toxicity, guess what? This drug can also cause IDH differentiation syndrome. So we need to know that about this patient group as well. And then other common toxicities associated with this drug, some myelosuppression, a little bit of GI toxicity. Efficacy results, the complete response rate was in the neighborhood of actually quite similar to what we saw with Enasidenib. So about 30 to 40% of patients responded, and about a third of the patients overall had a complete remission with this single agent oral drug. So again, a poor risk patient group. These are relapsed patients that had already failed chemotherapy. And when you look at the median survival, it's about 9 months. So that compared to standard chemotherapy, where you're only getting 4 to 6 months, to be able to spare the patient the toxicity of salvage chemotherapy and give them an oral drug in the outpatient setting, I think that's a win for patients. But again, this is only for patients that have the confirmed IDH1 mutation. Well, now's the bad news. The costs of these therapies. So the older drugs, Cytarabine and Daunorubicin, they're almost free, right? They're so inexpensive. The problem, though, is they go on shortage. So for those of you that work at hospitals that treat large numbers of these patients, you know that both Cytarabine and Daunorubicin had been on intermittent shortage for about the last 7 or 8 years, on and off. So that's an issue. For the liposomal formulation of Cytarabine and Daunorubicin, for Gemtuzumab, Ozogamicin, you're going to be looking at anywhere between $8,000 to $12,000 per cycle, depending on how large the patient is and how many vials you have to use. The Enasidenib, it's an oral specialty medication. Anyone working in specialty pharmacy here? No one. Wow. Usually, okay, we have one in the back. So that's kind of the going rate for oral specialty medications now, about $25,000. Ivosidenib, which I had already turned in my slides after I got this cost data, is running about $1,000 per day, so about $30,000 a month. You know, I just made light of the cost of these different drugs, but we all know that there's lots of different costs that need to be taken into consideration in patients that are going through treatment with AML. What are the hospital-related costs? What are the transfusion-related costs? What are the costs related if they end up in the ICU? All of those things need to be taken into account because the hospital bill for induction chemotherapy for anybody that goes through this is going to be at least 6 figures, and that's if they do well. If they get sick and they end up in the ICU, it's probably going to end up in the millions. So we're not done. So there is likely to be more agents that get approved in the AML space within the next year or two. So hopefully the next time you guys have a lecture on acute myeloid leukemia, instead of 5 drugs, there's 8 or 10 more drugs that are out there that can be used not only in the relapse setting, but also earlier on in induction. And here's just a handful of those which are in advanced clinical trials right now. Now, what do we do? What's our job in taking care of this patient group? This is one of the more complex groups of patients to take care of. I mean, taking care of these patients is right up there with taking care of ICU level patients or solid organ transplant patients or bone marrow transplant patients. They can get sick in a hurry. You have to draw from a number of different knowledge bases in order to care for these patients appropriately. So you need to know about the drugs that they're getting, from the chemotherapy drugs to appropriate antiemetic support to appropriate anti-infective support. All of those things need to be taken into consideration, plus, practical things. Oh, are you going to give an intramuscular injection to someone with a platelet count of 2 when they can bleed? Or are you going to give someone with a platelet count of 7 a non-steroidal anti-inflammatory drug? No. Or aspirin or clopidogrel? No, you're not going to do any of those things. So we need to protect these patients and not allow foolish prescribing to take place while they're going through this rigorous intensive therapy. There's a lot of medication safety issues when it comes to taking care of these patients, which of course we're the stewards for. We own that. The toxicities and the teaching that goes on with this. So I work at a teaching hospital, so every month we would have new medical residents come in. And they knew almost nothing about taking care of leukemia patients. But, the nurse clinician and myself, we were the 2 folks on the team that were the consistent players. So we could tell them, oh, well, when we give this regimen, these things happen to these patients. So these are the things you're going to want to have on your call orders and things like that. So we really have, in my opinion, an outsized role in teaching our fellow pharmacists, our physician colleagues, our nursing colleagues about the appropriate way to use medications in this very sick, fragile patient group. And we also, one of my favorite things to do with these patients is to teach them. If you think about it from a patient standpoint, they've just been told over a period of a couple of days that they have a life-threatening illness, that they have a very low chance of making it to 5 years with surviving. So their world is spinning, And whatever we can do to educate them about what their treatment is and how it's going to be handled and all the safety measures that are going to be put in place to put their minds at somewhat of ease while they're going through this, and teaching their family about how all of this shakes out from the initial therapy to follow-up therapy and what is bone marrow transplant. All that stuff is really important, and we get to know these patients very, very well because they're in the hospital for a month. So you see them every day for 30 days or so. So you get to develop a really, I think, warm rapport with the patients and their family members that is very important and appreciated by the patients and their families. So we have new agents for this disease. When I was preparing for this lecture, I pulled an article, and it said one of the first things in the first paragraph in the article was talking about some of these newer agents. It said for 4 decades, research in acute myeloid leukemia was referred to as the boulevard of broken dreams because everything that was tried just didn't work. So now we have several new options which actually do work. I don't think anyone is, we saw the data, the raw data as far as survival is concerned. I don't think any of us is under the misimpression that these new therapies are going to cure patients. But they are, to use a baseball analogy, since everyone's in the throes of the pennant race, these are all solid singles. Okay, so all of these treatment options do make a difference for patients, and an uptick of several months of overall survival is meaningful in this disease group. Thank you.